Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today I'm delighted to be joined by Dr. Vivian Lee. She is the president of health platforms at Verily and also a senior lecturer at Harvard Medical School. Dr. Lee, thanks for joining me today.
Hey, so great to be with you, Nick.
So lots to talk about. You obviously focused on the Verily organization and all of the resources that you're bringing to bear to improve healthcare. But you wrote a book that has triggered a lot of discussion. Certainly, I think an essential read for anybody. Tell us a little bit. You have a pretty illustrious background, let's be frank here. Share a little bit about how you got to where you are and how that's guided your whole thinking around the long fix.
Well, when I set out to become a doctor, I had, I think, probably a very traditional view of what healthcare and medicine would be like. I had shadowed a physician in our hometown when I was in junior high, and I really thought healthcare was about caring for patients, really getting to know them, understanding them as people, and then hopefully helping with their medical conditions. And by the time I emerged from a decade and a half of training, as you well know, and then got into the practice, and I was also doing some research and some teaching and got pulled into more administrative work, kind of unsuspectedly, really, or unexpectedly, really. Should I start that sentence again? As I got drawn into the practice of medicine and teaching and research, I came to realize that I had a very little understanding of actually how healthcare worked. And that became particularly apparent as I got drawn into administration. So I became the chief scientific officer at NYU. And while I was there, I became very interested in this question of why our healthcare systems were not performing as well as people hoped. And from a research perspective, I invested a lot in areas of research that could support it, like folks from the business school or behavioral economists or population health and epidemiologists, for example. And from that point, I became just really interested in how academic healthcare systems could really improve healthcare through that multidisciplinary, interdisciplinary kind of approach. And so pretty much unexpectedly, I was asked to look at a position at the University of Utah to help lead that healthcare system. Didn't really know anybody in Utah, wasn't particularly connected to that state. But that year, the University of Utah had been ranked number one in quality and safety among all university healthcare systems in the country. And NYU had also been in the top 10, but not number one. And so we were pretty interested in what they had been doing so successfully. And also Intermountain Healthcare was doing some very impressive things in Salt Lake City. And so when the search firm called me up and said, well, come out, take a look, I actually took them up on the offer because I was just curious about the successes that were taking place there. And long story short, ended up moving the family out there and leading that healthcare system for 6 years, became a student of successes across the country, actually, because we really could learn and benefit from the great work that others had done. And after 6 years of leading that healthcare system, had the benefit of 1 year sabbatical, which is when I wrote the book, The Long Fix, had a chance to interview even more people and talk to even more people, visit more sites during that time. And then as I was thinking about what to do next, considered leading another healthcare system, but also became very intrigued by the notion of how to scale successes. And that's actually what ultimately drew me to Verily, a health technology company, which I think that space has the potential to maybe leapfrog some of the barriers that we're facing in healthcare. But nonetheless, was able to finish up the long fix. I'm very, very interested in seeing people's responses and the ability to perhaps maybe even influence some thinking.
So as you think back to that sort of serendipity moment of moving to Utah, they were number one. You know, there's a couple of things that stand out with Intermountain, that they have a I think, a pretty cohesive group, both of patients, but also, centered around that state that has allowed them, a little bit like Kaiser had sort of control of its population. Did that contribute to their capacity to really improve care? Was that a component that you think others can learn from? Or what else was going on? What did you see as you arrived there, as you became this student in this environment?
There were a number of characteristics, some I think specific to Utah and Salt Lake City, and some that were unique to both the University of Utah and Intermountain Healthcare. First of all, Utah is actually one of the healthiest states in the country. Maybe, there are many different factors there, but it is one of the healthiest states in the country, and has the culture of the community in Salt Lake, I think, has very high standards, and sets very high standards, particularly for its healthcare systems, which I think is terrific. What you described, the fact that Intermountain was both a large provider system with clinical facilities across the state of Utah as well as Idaho, as well as a large health plan, Select Health, really did create a very interesting environment, because they were able to directly incentivize or pay for initiatives and programs that they believed would improve patient outcomes and reduce the cost of care. And they could respond and change much more rapidly because they could do it all internally within their own system. They also employed most of their physicians. So that was also, I think, a very useful attribute. The third piece of, I think the third factor was data, that both the University of Utah and Intermountain had very deep roots. And I talk a little bit about one of the leaders, Homer Warner, who was actually the chair of the first department of biomedical informatics in the country, which happened to be at the University of Utah. But he worked both in the Intermountain system and in the University of Utah in establishing what was the first really somewhat primitive but effective electronic health record, which then led to the first enterprise data warehouse, which was incredibly powerful for building what we refer to as a learning health system, where you can actually collect data from all the patient experiences and learn from those data and continuously improve. So I think those were three really important factors for both the University of Utah, actually, and Intermountain Healthcare. And actually, the healthy rivalry between the two, I think, was also really powerful, especially from the academic perspective, to have a high-performing, low-cost community health system right there in your backyard really forced us to think at the university about how to keep our costs down, which is often a challenge in academic medical systems.
Yeah, so it's interesting you bring up the healthiness of the state. And, one of the things that I think is apparent for many of us is that an awful lot of health is actually taking place outside of healthcare. And what we deliver is sick care versus well care. And part of me thinks that the opportunity around influencing that is not so much in the control, although clearly it was with Utah, or maybe that was just a piece of data that contributed to their success. How do we fix that? Because that's where we're suffering, especially here in the United States, and it appears like we've exported a lot of this. How do we fix the outside of healthcare, where 60 to 80% of modifiable health is lifestyle?
Well, you'd expect ordinarily that the healthcare system and a strong public health infrastructure would be working collaboratively in a way to advance the health of the population. That's what you would hope. And I think what we've really found, or where we've evolved in the country, is that our healthcare delivery system, because we are fundamentally a fee-for-service model, we are really paying healthcare providers and healthcare systems simply to do as much as possible to us, regardless of whether it makes us healthier or regardless of whether it could even be, for example, preventive of sickness, as you say. As a result, we have a huge chunk, and by far the vast majority of the dollars focused on not focused on health. And then we have, I think, an eroding public health system in the country, which we have seen that has been made so apparent in the COVID crisis right now, that as a result, both components that should be really looking after health, focusing on prevention, wellness, all of the things, as you say, that take place outside of the walls of the clinics and hospitals, we're really falling short as a society. And as a result, we're paying dearly because by the time, as you well know, by the time the patient or the individual who could have been healthier throughout their lives, by the time they show up with a heart attack or a stroke or long-term consequences of diabetes, it's just much more expensive and much more suffering for naught, really.
So that exposure earlier on and influencing really drives the opportunity of pivoting to a different kind of healthcare system. But tied up with that is this fee for service, which is a sort of core component of our current system. We've been talking about since, I want to say it's 2015, maybe it was before that, of the move away. And there's been some success. I think Medicare Advantage is certainly one. There was, historically, I think HMOs and other principles of, pay to deliver better health. And what it reminds me of constantly, and I've sort of referenced this, is the Chinese medicine style of pay the physician whilst you're healthy, but stop paying him when you fall sick, was the simplest version of that I used to explain. How do we get from this fee for service to a pay to do good or to get better, healthier populations?
Well, as you say, I think one factor is to really study the examples that have worked. So we need to figure out, well, I guess there are really two components. One is we need to really modify the way in which we pay for healthcare. So if we think about paying for better health, as you say, or simply just transferring the responsibility of health outcomes in the way that we pay by doing something called global payment or capitated payments, which is how, for example, the military health system is run and the VA health systems are run. They're simply paid a fixed amount of money per month, per year to care for a population. The Medicare Advantage model has tried to do something very similar for our seniors, paying groups of physicians a fixed amount of money per month to care for each patient, paying a little bit more when the patient's a little bit more complicated and has multiple conditions, a little less if they're healthier overall. In all of these models, I think we're at least starting down the right path because we are incentivizing physicians and patients to really focus on better health and better outcomes and prevention. And then the second component, once you have the incentives aligned and once you can advance some of these payment models, is to really equip both the patient and the clinician with the right tools to be successful in this, so that they don't all necessarily have to relearn some of these capabilities, and so that they can actually be assured of more success. So I think we have a lot of lessons to learn from the military system and from, for example, some of these Medicare Advantage groups that I write about in The Long Fix. So, for example, ChenMed and Iora Health and Oak Street Health, many of these Medicare Advantage programs realize that in order to provide great care for seniors and to keep them out of the hospitals and independent, it's really important to be seen and to spend time with them in the clinic. So they will spend 30 minutes to an hour with each patient. They make sure that if transportation is an issue, they provide shuttle services or other transportation, pharmaceuticals, and making sure they can get their refills conveniently. So they have on-site pharmacies, and they'll even do Tai Chi or yoga classes in their clinics after hours as part of the falls prevention strategy, for example. And they've shown pretty consistently that with the right upfront investments, that they are able to reduce hospitalizations and emergency room visits and reduce the cost of care overall. Having some of those models and sharing some of those best practices will really enable other groups to learn from their mistakes and to kind of make that transition much more successfully. And similarly, I think there are many lessons from the military health system that I also share in the book that we can adapt in the civilian side. And so I think ensuring that people can successfully make that transition, when I say people, I mean both patients and clinicians, is really important because we live on such thin margins in the business that there's not a lot of appetite for change and for risk. And so trying to de-risk some of these changes is, I think, a very important part of the strategy for changing healthcare in this country.
For those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Vivian Lee. She is the president of Health Platforms at Verily and also a senior lecturer at Harvard Medical School. We were just talking about the success of Medicare Advantage. I mean, I think very clearly, saving money with some relatively simple efforts and, non-medical in some instances, certainly based on the examples that we hear about from there. But one of the things that keeps occurring, or feels to me that keeps occurring, is there's just huge resistance from the healthcare systems in place who say, as you put it, the de-risking. How do you de-risk this so that they're not feeling like they're under an onslaught that essentially diminishes their role? They want to persist and they deliver value, but the system as it currently works is paying them. The new system wouldn't pay them enough, perhaps. Where's our flex point? How do we pull them across into this new world?
Well, maybe a couple of examples I think would be worth discussing. So one is some work that we did at the University of Utah when we were faced with this same pretty radical pivot. We were told that, so what happened almost overnight in the state of Utah was that our Medicaid program announced that it would completely change its payment approach. So initially it had been fee-for-service. So every time we saw one of the state's Medicaid patients that we were responsible for, every time they came into the emergency room or got an imaging study, we would simply bill Medicaid and we would get paid. And then the office announced, no, as of January 1st, the following year, we were going to get paid a fixed amount of money for each of those patients that would have to last the year. And if it didn't last the year and we had to image the person in the MRI scanner or perform a procedure or whatever, those costs would be on those would be ours to bear. And that really was a shock to the system. We didn't even have the data systems to understand how those patients had even performed over the past year. And once we did, we found, for example, this patient that had been in our emergency room more than 50 times in the previous year. And I'm sure we knew about her. I'm sure everybody in the emergency room knew her well. I'm sure on a first name basis. And yet every time she would be discharged, back out again and come back in again. Once we discovered that she was going to be our responsibility, it became a much more urgent need to get her a primary care physician, to make sure that she had transportation to come to the clinic to be seen if there were any issues, to make sure she could get her refills. And we made those investments. We also, so one piece of it is to make sure that systems actually are able to invest in the right kinds of, I call it infrastructure or data or management tools, whatever you want to call it, to be able to succeed in a world in which we are paid differently. Because all of our tools and management structure right now is set up to encourage people to do as much as possible. You know, when I first arrived in Utah and I was walking down the halls, the little color bar charts on the walls that were basically indicating, performance of different medical groups just was shown. All it revealed was how many procedures every doctor was doing. The number of echocardiograms, the number of catheterizations, the number of operations they did. There was nothing charting whether we were improving better outcomes, whether we were lowering the cost of care. We don't have that. So we spent some time both building some of our own tools and then just shopping out in the market for tools that were already available to be able to measure costs and to be able to measure outcomes so that we would know that as the payment model changed, we would be able to respond and we could actually do so with a reasonably high likelihood of success. And once we knew that, then we actually would be willing to take on that risk. A little bit more, a different perspective, because I'm giving you kind of the hospital perspective. Mm-hmm. One perspective that I think is also worth thinking about, of course, is the physician's perspective on willingness to take a risk. And one of the observations that I made when I was writing the book was to compare and contrast the military health system with the civilian side with respect to medical education. So in this country, as you well know, medical school is extremely expensive, and the average student who graduates in debt has about $300,000 of debt that they're bearing. I have colleagues who've just barely finished paying off their medical school debt. And so that also creates a disincentive, or maybe the wrong kinds of incentives, I think, for our physicians, because you come out and even if you want to practice primary care, family medicine in a rural setting, even if that is your passion, that is why you came into medicine, it's just, you're really disincentivized because of the debt issues, and you're incentivized to become a high-end, orthopedic surgeon, cardiac surgeon, dermatologist in an urban area where they probably don't need any more, but that's what you're incentivized to do. So the military health system has this model where you can go to medical school and even college, essentially have your tuition covered, even get paid, during parts of it, and then in return you provide service. And of course, there are sort of light versions of that, I would say, in some states with rural medicine loan forgiveness programs, but they really aren't particularly generous, and they don't make up this difference in salary that we were just talking about. So I also think there are much more upstream ways in which we can think about changing our healthcare system, starting from how we think about medical education, that can really affect over time the ways in which we how we provide care, what we emphasize in our communities, how we can get back to what's the most important, in my view: primary care, preventive medicine, community medicine, which right now are pretty much disincentivized because of our fee-for-service and our education models.
So in the few minutes remaining, if you could just comment a little bit on the challenges and potentially the opportunity around COVID-19. And I always hesitate to say the silver lining, but I'm always seeking silver linings in crises. And, to your point of this shift, does this provide a shift to potentially accelerate our move towards some of these better models that, clearly are offering value and as a result need to give us a better way of delivering healthcare and allowing us to get to better health system?
Well, we're seeing a lot of lessons from the COVID crisis. For example, we talked about the Medicare Advantage programs, and because they are paid on a per month basis, those medical groups are proving much more resilient than your standard fee-for-service clinics and hospitals. They did not have to furlough their doctors and nurses during the COVID crisis, for example, and they were able to make the right investments for their patients, even during the peak, the worst of the COVID pandemic. We've also seen telehealth, for example, really accelerate into widespread use. And that has been taken years. When I was in training, we were already doing teleradiology, and we really needed the pandemic to really shift that. Although I will say that with advances like telehealth and digital health, it's really imperative that we make sure we don't recapitulate the same challenges of fee-for-service. I actually had to make an appointment for one of my family members to get a COVID test recently, and I was told by the receptionist, this call is we are going to bill your insurance for this call because it's going to count as a telehealth visit. And I thought that was a classic example of the fee-for-service, the completely wrong incentives that fee-for-service sets up. So if we do that for telehealth, it's really going to create a bad situation. So there are opportunities as we advance into more telehealth and digital health to really pay for outcomes and not pay for every time we talk to somebody, in this case, over the phone. So we see opportunities to accelerate change. I see them, and it's really, I think the basic lesson is as Churchill said, never waste a good crisis. And so we have real opportunities and appetite for change now. We just need some leadership and some vision to get us moving in the right direction faster.
Fantastic. Well, as always, we've run out of time, unfortunately. It just remains for me to thank you for joining me. I would say that the resounding point I hear is use the crisis, but learn from the past, and importantly, the data and the experiences where we can show the value. I just, a huge opportunity, and I want to thank you for joining me and encourage everybody to read the book. I think easily to understand no matter where you come from, and such an important area for everybody to really understand. Dr. Lee, thanks for joining me today.
Thanks so much, Dr. Nick. Great to be with you.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, The Incrementalist, or share with me at DrNick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com, and tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, The Incrementalist, and I'm starting a revolution through evolution.